Study section 12. Changes and adaptation in pregnancy. Introduction. In the previous study section, you have learned about the developmental tasks of the childbearing mother, the childbearing family, and preconceptual care. Every pregnancy is different, but many women find that some bodily changes are uncomfortable. Fortunately, after the baby arrives, most women find relief from these symptoms. In the meantime, there are ways to decrease some of the discomfort. In this study section, you will learn about the changes and adaptation in pregnancy and the physiological changes in pregnancy. Learning outcomes. At the end of this study section, you should be able to 1. Discuss the changes and adaptation in pregnancy. 2. Explain the physiological changes in pregnancy. Changes and adaptation in pregnancy. Take 2. Changes and adaptation in pregnancy. Pregnancy is an amazing time of growth, both for mother and baby. As a new life is growing within a woman, her body undergoes many changes due to hormones. The first trimester of pregnancy can be easy for some women. Figure 12 of 1, the first trimester of pregnancy. For others, these first 3 months can be the most challenging time of pregnancy due to the following common symptoms. 1. Tiredness. It is common for many women to feel very tired in the first few months of pregnancy. Try to get at least 8 hours of sleep and take naps if needed. 2. Shortness of breath. As pregnancy progresses, a large uterus puts pressure on the diaphragm, making it less able to move freely during breathing. This causes some women to feel short of breath. Women should seek help if severe. 3. Breast tenderness. As breasts change to prepare for breastfeeding, they often become tender within the first 8 weeks of pregnancy. Throughout the pregnancy, the tenderness may come and go, especially as breast gets bigger. Colostrum, an early form of breast milk, may even leak out in the second and or third trimesters. Women should wear a supportive bra. Avoid using soap on the breast, as this tends to dry out the skin. Wear bra pads if breasts are leaking. 4. Nausea and vomiting. Many women have feelings of nausea and vomiting during pregnancy. It usually occurs between 6 to 16 weeks of pregnancy. Although it is often called morning sickness, women may have the symptoms at any time of the day. Encourage women to eat small, frequent meals. Drink liquids in between meals, not with meals. Eat dry crackers before getting out of bed in the morning. Avoid smells, foods, or other stimulations that triggers your nausea. 5. Constipation and bloating. Hormones cause the gut to slow down its normal movement, which can cause bloating and constipation. Iron supplements, which are often needed, may make constipation worse. To avoid this, women should drink plenty of water and non-caffeinated fluids each day. Eat fiber-rich foods such as fruits, vegetables, and whole grains. Remain active. Talk to your doctor before taking laxatives. 6. Frequent urination. Hormones are to blame for frequent urination in the first trimester. As the pregnancy progresses, a growing uterus puts pressure on the bladder. Therefore, frequent urination is often a discomfort for many women throughout the pregnancy. 7. Heartburn. Many pregnant women have heartburn in the third trimester. Pregnancy hormones loosen the muscle that closes off the esophagus from the stomach. When this happens, stomach contents can back up into the esophagus, causing the burning sensation known as heartburn. A growing uterus also squeezes the stomach, which contributes to heartburn. This can be minimized if pregnant women eat small, frequent meals and also avoid high-fat foods, spicy foods, and caffeine. 8. Leg cramps. Leg cramps usually occur in the calf muscles during the night and are thought to be related to inadequate calcium or magnesium intake. Talk to your doctor about whether you need increased amounts of these nutrients. A growing uterus also squeezes the stomach, which contributes to heartburn. This can be minimized if pregnant women eat small, frequent meals and also avoid high fast foods and spicy foods and caffeine. 9. Ankle or leg swelling. Most pregnant women have some leg swelling due to the extra volume of blood providing circulation to the placenta and baby. The uterus puts pressure on the large blood vessel, draining blood from the lower half of the body, which can cause edema, limit sodium from foods. 10. Varicose vein and hemorrhoids. Varicose vein on the legs and hemorrhoids often cause Varicose vein on the legs and hemorrhoids often occur during pregnancy due to increased blood volume. Prevent constipation. Eat a high fiber diet, fruits, vegetables, whole grains. Avoid prolonged periods of standing or sitting. Physiological changes in pregnancy. These are the normal adaptations that a woman undergoes during pregnancy to better accommodate the embryo or fetus. Diagram of physiological changes in pregnancy. A. First trimester, B. Second trimester, and C. Third trimester. They are physiological changes, that is, they are entirely normal and include cardiovascular, hematologic, metabolic, renal, and respiratory changes that becomes very important in the event of complication. 1. Hormonal. Pregnant women experience adjustment in their endocrine system. Levels of progesterone and estrogen rise continually throughout pregnancy, suppressing the hypothalamic axis and subsequently the menstrual cycle. Estrogen is mainly produced by the placenta and is associated with fetal well-being. Women also experience increased human chorionic gonadotropin (BCG), which is produced by the placenta. This maintains progesterone production by the corpus luteum. The increased progesterone production, first by corpus luteum and later by the placenta, mainly functions to relax smooth muscle. Prolactin levels increase due to maternal pituitary gland enlargement by 50%. This mediates a change in the structure of the mammary glands from ductal to lamellar alveolar. Parathyroid hormone is increased, which leads to increases of calcium uptake in the gut and reabsorption by the kidney. Adrenal hormones such as cortisol and aldosterone also increase. Human placental lactogen (HPL) is produced by the placenta and stimulates lipolysis and fatty acid metabolism by the woman, conserving blood glucose for use by the fetus. It can also decrease maternal tissue sensitivity to insulin, resulting in gestational diabetes. One of the most noticeable alterations in pregnancy is the gain in weight. The enlarging uterus, the growing fetus, the placenta and liquor amnion, the acquisition of fat and water retention all contribute to this increase in weight. The weight gain varies from person to person and can be anywhere from 5 pounds, 2.3 kg, to over 100 pounds, 45 kg. In America, the doctor recommended weight gain range is 25 pounds, 11 kg, to 35 pounds, 16 kg. Less if the woman is overweight, more up to 40 pounds, 16 kg if the woman is underweight. Take 2. If the woman is underweight. 2. Breast size. A woman's breast grows during pregnancy, usually 1 to 2 cup sizes and potentially several cup sizes. A woman who wore a C cup bra prior to her pregnancy may need to buy an F cup or larger bra while nursing. 3. Cardiovascular. The woman is the sole provider of nourishment for the embryo and later the fetus, and so her plasma and blood volume slowly increase by 40 to 50% over the course of the pregnancy to accommodate the changes. The increase is mainly due to an increase in plasma volume through increased aldosterone. It results in an increase in heart rate, 50 beats per minute more than usual, stroke volume, and cardiac output. Cardiac output increases by about 50%. Mostly during the first trimester, the systemic vascular resistance also drops due to the smooth muscle relaxation and overall vasodilation caused by elevated progesterone, leading to a fall in blood pressure. Diastolic blood pressure consequently decreases between 12 to 26 weeks and increases again to pre-pregnancy levels by 36 weeks. If the blood pressure becomes abnormally high, and the woman should be investigated for preeclampsia and other causes of hypertension. This is due to an increase in plasma volume, through increased aldosterone. Progesterone may also interact with the aldosterone receptor, thus leading to increased level. Red blood cells numbers increase due to increased erythropoietin levels. 4. Hematology. During pregnancy, the plasma volume increases by 50% and the red blood cell volume increases only by 20 to 30%. Consequently, the hematocrit decreases on lab value. This is not a true decrease in hematocrit, however, but rather due to the dilution. The white blood cell count increases and may peak at over 20 mg/ml in stressful conditions. Conversely, there is a decrease in platelet concentration to minimal normal volume of 100 to 150 ml/ml. A pregnant woman will also become hypercoagulable, leading to increased risks for developing blood clots and embolism due to increased liver production of coagulation factors, mainly fibrinogen and factor V. This hypercoagulable state, along with the decreased ambulation, exercise involving legs, causes an increased risk of both deep vein thrombosis. Women are at higher risk for developing clots or thrombi during the weeks following labor. Clots usually develop in the left leg or the left iliac venous system. The left side is most afflicted because the left iliac vein is crossed by the right iliac artery. The increased flow in the right iliac artery after birth compresses the left iliac vein, leading to an increased risk for thrombosis, clotting, which is exacerbated by the aforementioned lack of ambulation following delivery. Both underlying thrombophilia and cesarean section can further increase this risk. Oedema or swelling of the feet is common during pregnancy, partly because the enlarging uterus compresses vein and lymphatic drainage from the legs. 5. Metabolic. During pregnancy, both protein metabolism and carbohydrate metabolism are affected. 1 kilogram of extra protein is deposited, with half going to the fetus and placenta, and another half going to uterine contractile protein, breast, glandular tissue, plasma protein, and hemoglobin. An increased requirement for nutrients is given by fetal growth and fat deposition. Change are caused by steroid hormones, lactogen, and cortisol. Maternal insulin resistance can lead to gestational diabetes. Increased liver metabolism is also seen, with increased gluconeogenesis to increase maternal glucose level. 6. Nutrition. Nutritionally, pregnant women require a caloric increase of 300 kcal a day, or an increase in protein to 70 or 75 grams per day. There is also an increased folate requirement from 0.4 to 0.8 milligram per day, important in preventing neural tube defects. On average, a weight gain of 20 to 30 IB, 7.1 to 14 kg, is experienced. All patients are advised to take prenatal vitamins to compensate for the increased nutritional requirements. The use of omega-3 fatty acids supports mental and visual development of infants. Choline supplementation of research mammals support mental development that lasts throughout life. 7. Renal. A pregnant woman may experience an increase in kidney and ureter size. The glomerular filtration rate, GFR, commonly increases by 50%, returning to normal around 20 weeks postpartum. Plasma sodium does not change because this is offset by the increase in GFR. There is decreased blood urea nitrogen, BUN, and creatine and glucosuria due to saturated tubular reabsorption may be seen. Persistent glycosuria may suggest gestational diabetes. The renin-angiotensin system is upregulated, causing increased aldosterone levels. 8. Gastrointestinal. During pregnancy, women can experience nausea and vomiting, morning sickness, which may be due to elevated blood human chorionic gonadotropin, and should resolve by 14 to 16 weeks. Additionally, there is prolonged gastric emptying time and increased gastroesophageal sphincter tone, which can lead to acid reflux. Increased colonic motility, which leads to increased water absorption and constipation. 9. Immune tolerance. The fetus inside a pregnant woman may be viewed as an unusually successful allograft since it genetically differs from the woman. In the same way, many cases of spontaneous abortion may be described in the same way as maternal transplant rejection. 10. Respiratory. Progesterone has noticeable effect on respiratory physiology, increasing minute ventilation by 40% in the first trimester. 11. Nausea, morning sickness. Morning sickness occurs in about 70% of all pregnant women and typically improves after the first trimester. Although described as morning sickness, women can experience this nausea during afternoon, evening, and throughout the entire day. 12. Musculoskeletal. Neuromechanical adaptation to pregnancy refer to the change in gait, postural parameters, as well as sensory feedback due to the numerous anatomical, physiological, and hormonal changes women experience during pregnancy. Such changes increases their risk for musculoskeletal disorders and fall injuries. Musculoskeletal disorders include lower back pain, leg cramps, and hip pain. Pregnant women fall at a similar rate, 27% to women over age of 70 years, 28%. Most of the falls, 64%, occurs during the second trimester. Additionally, 2/3 of falls are associated with walking on slippery floors, rushing, or carrying an object. The root causes for these falls are not well known. However, some factors that may contribute to these injuries include deviation from normal posture, balance and gait. The body's posture changes as the pregnancy progresses. The pelvic tilts and the back arches to help keep balance. Poor posture occurs naturally from the stretching of the woman's abdominal muscles as the fetus grows. These muscles are less able to contract and keep the lower back in proper alignment. The pregnant woman has a different pattern of gait. The step lengthens as the pregnancy progresses due to weight gain and changes in posture. On average, a woman's foot can grow by half size or more during pregnancy. In addition, the increased body weight of pregnancy, fluid retention, and weight gain lowers the arches of the foot, further adding to the foot length and width. The influences of increased hormones such as estrogen and relaxin initiate the remodeling of soft tissues, cartilage, and ligaments. Certain skeletal joints such as the pubic symphysis and sacroiliac widen or have increased laxity. 13. Back pain. Back pain is common in pregnancy, can be very debilitating, and can worsen in later pregnancy. Estimates of prevalence ranging from 35% to 61% have been reported, with half or more beginning from the 5th month. It is believed to be caused by changing posture and can be worse in the evening. Trials have shown benefit from exercising in water, massage therapy, and back care classes. Support from pillow while sleeping might be able to help. Back care classes for pregnancy include a variety of exercises and guidance. General attitude. Take 2. General exercise that is not tailored to strengthen the back may not prevent or reduce back pain, but more research is needed to be sure. Maternity support belts have not been shown to reduce lower back pain in pregnancy. they may have some adverse effects, including pain and skin irritation for the mother and potential effects on the fetus. 14. Pelvic and girdle pain. Pelvic girdle pain is complex and multifactorial and likely to be repressed by a series of subgroups with different underlying pain drivers from peripheral or central nervous system, altered laxity or stiffness of muscles, laxity to injury of tendinous or ligamentous structure to maladaptive body mechanics. Muscular skeletal mechanics involved in gait and weight-bearing activities can be mild to grossly impaired. Pelvic girdle pain can begin peri or postpartum. There is pain, instability or diffusion in the symphysis pubis and or sacroiliac joints. 15. Carpal tunnel syndrome. This occurs in between an estimated 21% to 62% of cases, possibly due to edema. 16. Leg cramps. Leg cramps, that is spasms in the calves, can be very painful and possibly affect almost half of all pregnant women. Leg cramps usually occurs at night, lasting from seconds to minutes. Although a variety of interventions such as compression, stockings, salt, calcium, and magnesium are sometimes used, it is not known whether any are both effective at reducing leg cramps and safe for the fetus. 17. Constipation. Constipation is believed to be caused by decreased bowels mobility secondary to elevated progesterone, normal in pregnancy, which can lead to greater absorption of water, but it can also be caused or worsened by iron supplementation. It causes the smooth muscle along the walls of the intestines to relax, thus making sure that the future mother will absorb as much nutrients from our diet as possible in order to nourish the fetus and herself. As a side effect, the fetus can get extremely dehydrated and hard to pass. Constipation can decrease as pregnancy progresses, with a rate as high as 39% with a rate as high as 39% at 14 weeks of gestation, reducing to 20% of 36 weeks in one study at a time when iron supplementation was common. Dietary modification with more fiber or fiber supplements at increased oral fluid took softeners, bulking agents, and eating fruit and fiber enriched foods often help. A woman experiencing sudden defecation should report this to her practitioner. Number 18. Contractions. Occasional, irregular, painless contractions that occur several times per day are normal and are known as Braxton Hicks contractions caused by dehydration, treatment, fluid intake. Regular contractions every 10 to 15 minutes are a sign of preterm labor and should be assessed by cervical examination. 19. Edemal. caused by compression of the inferior vena cava (IVC) and pelvic veins by the uterus, leads to increased hydrostatic pressure in lower extremities. Treatment: raising legs above the heart. Patient sleeps on her side. Dehydration caused by expanded intravascular space and increased tau spacing of fluid. Treatment: fluid intake. Complication: uterine contractions, which may occur because dehydration causes body release of antidiuretic hormone, which is similar to oxytocin in structure. Oxytocin himself can cause uterine contractions, and thus ADH can cross-react with oxytocin receptors and also cause contractions. 21. Regurgitation and heartburn. These are caused by relaxation of the lower esophageal sphincter (LES) and increased transit time in the stomach. Normal in pregnancy, as well as by increased intra-abdominal pressure caused by the enlarging uterus. It is treated with antacid, multiple small meals a day. Avoid lying down within an hour of eating. H2 blockers. Proton pump inhibitors. If more severe, it may be diagnosed as gastroesophageal reflux disease, GERD. 22. Hemorrhoids. Hemorrhoid piles are swollen veins. Take 2. Hemorrhoids. Hemorrhoids, also known as piles, are swollen veins at or inside the anal area, resulting from impaired venous return, straining associated with constipation, or increased intra-abdominal pressure in later pregnancy. They are more common in pregnant than non-pregnant women. Most pregnant women in countries where diet is not heavily fiber-based may develop hemorrhoids, although they will usually be asymptomatic. Hemorrhoids can cause bleeding, itching, swelling, or pain, and they can become strangulated. Symptoms may resolve spontaneously after pregnancy, although hemorrhoids are also common in the days after childbirth. Conservative treatment for hemorrhoids in pregnancy include dietary modification, local treatment, bowel stimulants or antidepressants, or phlebotomic, or to strengthen capillaries and improve microcirculation. Treatment with oral. Hydroxychloroticide may help improve first and second degree hemorrhoids, but more information on safety in pregnancy is needed. Other treatments and approaches have not been evaluated in pregnant women. 23. Pickle. This is cravings for non-edible items such as dirty or clay caused by iron deficiency, which is normal during pregnancy and can be overcome with iron supplements, prenatal vitamins, or, if severe enough, parenteral iron. 24. Lower abdominal pain. This is caused by rapid expansion of the uterus and stretching of ligaments, such as the round ligaments. Treatment: paracetamol, acetaminophen. 25. Increased urinary frequency. This is increased intravascular volume, elevated glomerular filtration rates, and compression of the bladder by the expanding uterus. It may appear rather sudden by head engagement of the fetus into cephalic presentation. Patients are advised to continue fluid intake despite this. Urinalysis and culture should be ordered to rule out infection, which can also cause increased urinary frequency but typically is accompanied by urinary pain when urinating. 26. Round ligament pain. This is pain experienced when the ligament positioned under the uterus stretch and expand to support the woman's growing uterus. In pregnancies that experience rapid fetus growth or women with particularly weak abdominal muscles, this pressure can sometimes cause the rectus abdominal muscle to separate along the lineal alba, creating a split between the left and right side of the rectus abdominis. About 1/3 of all pregnant women experience diastasis rectal at some point in their pregnancy. However, it is much more likely to occur during the second trimester or third trimester of pregnancy. However, separation also frequently occurs during labor and delivery, or with women carrying more than one baby. Many cases of diastasis rectal correct themselves after birth, but some do not. In cases where it persists, exercise may help improve the conditions, and sometimes surgery is needed to correct the problem to prevent pain and future complications. 29. Stretch gravidarum. Take 2. 29. Stretch gravidarum. Stretch gravidarum pregnancy-related stretch marks occurs in 50% to 90% of women and are caused both by the skin stretching and by the effect of hormonal changes on fibers in the skin. They are more common in younger women, women of color, women having larger babies, and women who are overweight or obese, and they sometimes run in families. Stretch marks generally begin as red or purple stripe rubra. Take 2. Stripe rubra. Fading to pale or flesh color, stripe rubral. After pregnancy, that will generally be permanent. Study section summary. In this study section, you have learned that 1. Pregnancy is an amazing time of growth both for mother and baby. The first trimester of pregnancy can be easy for some women. As a new life is growing within a woman, her body undergoes many changes due to hormones. 3. Physiological changes are the normal adaptations that a woman undergoes during pregnancy to better accommodate the embryo or fetus. End of study section 12. Thanks for listening.